So, welcome to the another episode of lectures for the fellows. It is DRA injuries, the treatment protocol. We'll be dealing with the decision making rather than procedures themselves. So, first we'll touch some amount of anatomy for the DREJ. TFCC, the articular disc, which contributes to the stability. There's a volar radioulnar ligament, like ulnar-lunate, ulnar ligament. They resist the dorsal displacement of the ulnar head, and the dorsal radial ligament, which resists the volar displacement of the radial ulnar head. Other secondary stabilizer which are dynamic are ECU and pronator quadratus. What is the clinical presentation? The clinical presentation is pain is localized. There's a localized tenderness. Pain is on the ulnar aspect of the DRUJ clicking, snapping sound. And piano key sign is classical, what you're seeing in the video. That is a classical piano key sign where there's a prominent bilateral distal ulnar head with full pronation of the distal forearm. Compression and then rotation will give you pain. That is again a sign of, I'll say, more of DRUJ arthritis. And resisted ulnar deviation causing snapping of ECU can also give rise to the pain from the ulnar aspect, which can arise from DRUJ or can be confused with DRUJ. Diagnostic imaging, I'll say X-ray. X-rays are when there's a zero rotational view, that is 1990 PA view of the wrist, in which the shoulder is at 90 and elbow is 90 and resting on the forearm like this, on the table. Forearm is resting on. This is a zero rotational view. CT scan gives the best comparison when you're comparing with the total pronation supination. So you have to take multiple CT scan, like we started doing 4D CT scans in which there were different rotation, and you're doing CT scan in different rotation to see when there is a subluxation, which movement there is a subluxation of the ulnar head. And MRI and dynamic arthrography is also helpful. I'll not touch upon it. I think we have discussed in one of the clinical radiological conferences. So acute traumatic DREJ problems, they usually or most commonly, they occur with the fractured distal radius. It is one of the most commonest cause of DREJ instability. When there is a distal radius fracture, there is an injury to the ligaments, there is a shortening of the distal radius, which can result in TFCC injury, or which can have a secondary traction injuries on the ligaments. Or there is a DREJ instability, and there is a pre-existing DREJ instability, and there is a fracture of the forearm with the second trauma. These are the few scenarios where we'll be talking about. There can be many more, but these are the true, we can say, fractures which can lead to DREJ instabilities. Something like this, there's a fracture both bones forearm, and you can see there's a ulnar plus deformity. If you look at the forearm, the amount of overlap is almost similar on the fracture side, but the ulnar plus deformity is there. So when we took the history, we found that there was a ulnar patient already had a pain on the wrist joint beforehand because of some childhood trauma. So we dealt with it. We did some amount of ulnar shortening. You can see that fracture is now not the like acute fracture. We have just did the shortening of the ulnar, but resecting small amounts from both sides. And this is what you can see is the Mueller's compression clamp, where we did the compression and did the plating. So we took care of the both bones forearm as well as DRJ at the same sitting. This is the DRJ after fixation. So this is one of the very uncommon examples, but we can decide. Or there could be something like the patient had a fracture for both bones forearm and had a radial shortening, and patient had a repeat trauma in which patient broke the radius. Here you can see that this is an old plate, DCP plate, which was applied in the previous trauma. And this is a revised one where we put a graft and did some amount of radial lengthening to get the correction of the DRJ. So in acute DRJ injuries, what is a dictum? Dictum is the DRJ is reducible and stable, just splint it for 2 to 3 days and then mobilize gently in a restricted way. If DRJ is reduced but it is unstable, that means you can ballot the ulnar head, then you have to splint it in a stable position. That means if DRJ ulnar head is stable in pronation, then you splint in pronation. If it is unstable, if it is stable in supination, then give splint in supination. If DRJ is reducible but not stable in any of the positions, in such cases you pin with the K-wire. DRJ, you have to pin it because you have to resist both volar and dorsal. And another scenario could be that DRJ is reducible. In such cases, you have to do open reduction and then stabilize the DRJ. So K-wire, I just want to say K-wire stabilization. This is one of the not good ways of doing DRJ. Why? Stabilization, one is like, okay, you have fixed the ulnar head by ulnar styloid to stabilize the DRJ, but your wire is going through the DRJ, through the joint. So that can cause permanent stiffness, or it can have bony spur formation or bone formation. Synostosis can happen in such condition. So it is always advisable that you apply proximal to the sigmoid notch. If you are doing proximal to the sigmoid notch, the chances of synostosis are very less. Many times DRJ is very unstable. In such cases, you can pass 2 wires to give more stability. And one must remember that, like you can see, can you see the arrow? So the wire should be a little bit out, not out of the skin, out on the bone, on the radial side. Suppose this wire breaks here because of force movement or something, you can retrieve your wire, one end from here, one end from there. So the trick is that you should leave wire outside the bone on the radial aspect, not too much because it will impinge, it can damage the nerve, little bit, so that you can just dissect and you can take it out in case of breaking of the wire. Or what we do nowadays, internal bracing using flexible fixation by using strong thread and 2 endo buttons. This also can stabilize. The beauty of this is you can mobilize them early and there is no breakage of the implant, and implants are not seen on the mother. The wire is not going through it, so no breakage of the implant, no need to remove the implant, and you can mobilize them early because you are not relying yourself on any tendon graft or anything. These are the threads. You can see that these are the 2 tunnels which are going through which you can pass non-absorbable wire or non-absorbable thread. Good thread number 2 or number 5, and use endo buttons. Malunited distal radius is a commonest presentation in our practice. Most of us see a lot of distal radius and see a lot of malunited distal radius, and we see a lot of DRJ instability. Suppose patient just treated with the pinning and the tilt was a little bit off. Though if you look at the radius, it is completely acceptable thing. But if you're looking at the DRJ, that is not acceptable. And when wires are removed, then DRJ is unstable. Though it is reducible, but it is unstable because DRJ was not addressed at that time. So the anatomical reconstruction as described earlier, you can use ECU or brachioradialis wrap or capsuloraphy just to have soft tissue reconstruction around the ulnar head to stabilize the ulnar head. So all these type of reconstruction, soft tissue reconstructions have been described, but most favorable one what we use is anatomical anatomical reconstruction, which was described by Adam Berger and published in 2002 in Journal Hand Surgery American. It was anatomical because it has volar limb and dorsal limb. It is attached to the fovea, so that gives more near anatomy reconstruction rather than all other reconstructions were all only around the ulnar head. So this is stood that time, and it has been a very useful procedure in our hands. So we'll just go through one of the example. This is the DRUJ instability. You can see that there's a gap. There's an ununited ulnar stellate fracture, and there's some amount of tilt. So this is how it is described by Adam Berger. There are two tunnels, one from the fovea to the base of the stelloid, and another is anterior-posterior tunnel just lateral to the sigmoid notch. So it gives two volar and the dorsal ligaments which are attached on the fovea, and it wraps around the ulna to give more stability. If there is a problem in the length of the graft, then you can use anchors to attach it to ulna. So here anterior posterior drill is made using a drill guide. We prefer using a cannulated drill because we can have a guide wire and check under radiograph on C-arm whether it is perfect. If it is perfect, the way we want to do it, then we drill over the cannulated drill and make a tunnel, anterior posterior or volar dorsal tunnel. And if there is a if you want to correct a deformity, you can do it at the same time. But usually we don't mix it. We have done it a few times. Then our tunnel, usually if we are using a plate, then our tunnel really goes little bit lateral, so that tunnel comes out of from the window of the implant or just little bit away from the screws. So you can do osteotomy. It is okay if you do the osteotomy as well as DRG reconstruction. So this is what it was done. There is another example. This is a different patient now. There was a ulnar plus deformity with the DRG stability. So we did what we did. We did the ligament reconstruction as well as we did a ulnar shortening, or you can say a wafer procedure. Distal ulna was removed, and we reconstructed on the ulnar tricutal ligament also. So you can see anchor in the tricutum. So DREJ as well as ulnar tricutal ligament was reconstructed because it was completely unstable. So this was done. This is Adam Berger procedure with the ulnar shortening. We have done the ulnar shortening. So ulnar was length. You can see on X-ray also. You can see there's some amount of ulnar abutment. So once we have done an osteotomy, we did a posterior anterior graft has been passed. Then this is a dorsal limb. We are recreating a dorsal limb over the dorsal capsule. Then other limb has come from the volar side. These both limbs, they are passed through the ulna. Sorry, the video is fast because I just want to, we can have another talk on this. So ulna, and then we wrap around ulna and stitch it to the ulna to give the stability to the DREJ. So this was the same patient after this thing, reconstruction and good movements, and patient has asymptomatic. This is another patient. Oh, sorry. This is another case in which there is a injury which was missed in the emergency and treated as no-bony injury by the friends. She was a lady JR, and most of the orthopedic guys, they just more interested, not interested, I'll say not interested in the x-rays, and they miss this overlap at the DREG level. So she was treated as a injury. The odd about it, it was a volar dislocation. And how you do it, volar dislocations are often missed clinically as well as radiologically. This is the overlap, and you can see we got a comparison radiograph for the other side, and rotations were also restricted. So this patient was, we did more MRI was done. Now you can see that ulnar head is volarly dislocated. This is one of the rare incidences. It's not a very common. But just to complete it, that ulna can go volarly, so that on palpation you won't see ulnar head, dislocated ulnar head, and many times people do miss it. But if you clinically examine this patient, there will be a tenderness, there will be restriction of pronation, supination. So don't take it as a soft tissue injury and just let it go. In this, open reduction was done, ligament reconstruction was done, and the reconstruction, what we did was we used a anchor, and then we also did a double breasting of the dorsal capsule and stabilized with the K wire just to give a support, because this came to us 6 weeks late, so it was already a, you can say, neglected dislocation or chronic dislocation. So this is by the anchor, it is stabilized, and on the top of it there's a double breasting, and on the top of it there is K-wire fixation. Another case of DRUJ in which this is the time when people, this plate was new, ulnar plate was launched. So someone missed the DRUJ dislocation and fixed the ulnar styloid with disregarding the radiology of the DRUJ, and there's just afterwards there was a subluxation, or you can say dislocation. Though this fracture is well fixed, but DRUJ is completely unstable and painful and restricted. So when they came to us in this position, always, whenever in doubt, always compare with the other side. For few things we want to compare, whether it is ulna plus, ulna minus, or other side will tell us if there's any deformity, plastic deformity, or any tilt, opposite side will tell us. So always before going for a surgery, get a X-ray of contralateral sides just to give a comparison. So you know what you have to reconstruct and what should be your end goal, where your ulnar head should lie. So MRI was also done for the same patient. So this patient, because of the ulnar, this thing, again distal ulnar resection was done, and DRJ was stabilized. This is the volar dorsal tunnel, and you can see this is the ulnar tunnel. So this was stabilized, and patient was rehabilitated. Now you can see good flexion extension, good rotation. So the physiotherapy or rehabilitation is necessary to get good movements. So surgeon and doesn't finish, like the treatment doesn't end at the suture removal. You have to follow the patient, give the good functional result. This is another patient had a DRJ dislocation. Very aggressive physiotherapy was done. There was a volar subluxation with the degenerative changes. See, this was a result of very vigorous physiotherapy. I'll say, like you can just think how much ordeal patient had to really go, because ulnar head is somewhere here and you're creating a false joint here. By forcefully, this is a sigmoid notch, by forcefully trying to mobilize the dislocated ulna and causing all the ulna, you can see the cartilage is gone. So in this case, what we did a replacement with the DRJ stabilization using a tendon graft. So this was done using a tendon graft, though it is not a very recommended procedure, but I'll say patient didn't want a saw compange, and patient wanted a replacement. So this was done. Patient had good initial movement, and we have to see long-term results for this. Other things which are very good and give good results are salvage procedures, something like saw compandi, where you fix the DRJ and you create a pseudo orthosis at the base of the or distal ulna, so that there is a good pronation, supination. And what we do, we always stabilize the proximal fragment of the resected this thing ulna by using ECU or graft, or not graft, ECU tendon, hemi, ECU splitted hemi, and we just stabilize it, the stump of the ulna, so that pronation supinations are not very painful. Directs have been used many times, and I think is one of the most popular procedures in our country. But with our knowledge of DRUJ and other things, this is really going down because of the long-term effects. It keeps on impinging. You keep on resecting, it will keep on impinging. Just it is reminding me one of the cases which was presented by Green and one of the conferences where he had to, like, for 20 years he kept on resecting the ulna and kept on resecting for 20 years. He kept on resecting. Finally, he had to just fuse the small proximal part of the ulna with the proximal radius. Otherwise, there was like patient would come every year to get the resection done. So it is not a long term, it is not a very good procedure. Other thing first thing we discussed in the anatomy of DRJ, the TFCC. TFCC is one of the major stabilizers of the DRJ, and because it is a soft tissue for long, uh, it was you can say ignored, or our knowledge was not sufficient to get it this thing. First time it was described by in 1985. It was described for the again it was described on the anatomical specimens, and in which we'll be discussing. It was classified also. This is what schematic diagram of anatomy of the TACC. It is attached on the sigmoid notch, or you can say on the radius, and it is like a triangular. It attaches on the fovea. This place is called fovea, or base of the stelloid is on the ulnar, on the radial aspect, or on the articular surface is called fovea. Examination press test is very important, in which patient puts whole body weight and lifts himself or herself off the seat and put a weight on the DRJ. And if it is painful, it is almost 100% sensitive. It's not that specific, but sensitive. If you have a DRH injury, you're going to have pain. Other thing is TFCC load test. It is simple, in which you do the ulnar deviation, then you do pronation, supination, and if there is a pain, then test is positive. That is positive for the TFCC injury. Plain films, you might see that DRJ there is a gap, but you can't see DR, or there can be subluxation. But X-rays, you just see secondary migration of the ulnar head. Best thing is either MRI or arthrography or MR arthrography. They give the best, because with the availability of MRI more and more. So I'll say treatment of choice is MRI. This is how TFCC would look like. It is attached here. It is attached on the radius, and this is how superficial. You can see it is a superficial limb, and this is a deep limb which is attached on the fovea. We'll be discussing this on the TFCC lecture. But this is how TFCC tear would look like from the capsule, and this is how it would look like from the uh, central perforation, because leakage of dye. And this is how the complete tear with the fovea and the capsular would look like on a MR arthrography. In arthroscopy, we just do a trampoline test. If it is bouncing back like a trampoline, then it is intact, or will not go through. Same thing, if it is just bouncing back, that means most of the time TFCC is intact. They can be small tears, but if there's a major tear, it won't bounce back. So tears like this, which are more tears, something like this. This is a video. We just go through the steps how to do a capsular repair, in which what we are doing first, we debride the margins with using a shaver. You can see we can use either a long shaver or short shavers are available depending on what you have in your hospital. Once you have debrided the edges, Then we go for this is how you have debrided the edges. Now we go for the repair. We pass our needle, then through which we pass our PDS suture. Either we use PDS suture, which is long-term dissolver, or we use non-resorbable using a fiber wire kind of a suture. So this is taken out from the 6R portal, passing through the TFCC. Then we pass, this is a needle. You can see needle, we have passed the needle, goes through the skin, through the capsule. This is not a bony repair. And then we retrieved it from the 6R, you can see it is, or you can say 4-5 portal. So both are same, 4-5 or 6R, we can take it from there, retrieve it outside. Then we pass another needle, same way, with a loop inside, which goes through the capsule, not through the this thing. This is a simple suture. If you want to put a mattress suture, then you can pass through the TFCC. But here we are using simple suture because we want to bring them together. Mattress usually fails to bring them together, or tension becomes too high in mattress. So we prefer using one simple mattress in a Masonell technique. But we always put a one suture, which is simple suture, to bring the edges together. So this is how it is retrieved outside, and then bite is completed. And then you suture it outside, and this is how it look like. You can repeat this procedure as many times. So this was a Masonell mattress, in a case more complex tear in which multiple sutures were used. Or other thing, what we can use is a bony thing. Either we use freehand. If you have experience, you can use freehand, or you can use a guide in which two parallel pins are passed and threads are taken through the bony tunnel and fixed outside with an anchor, with an endo button. Or many times we just put it using a over the bony tunnel, over the bony bridge. So this is one of the cases. Again, this is a little bit long. You're putting your, this is how we do between a guide and other thing, more dissection and other thing. And it saves time doing it do with a guide. Then we pass a needle over it through the inside, that you can see the needle inside, and through which we can put our sutures in tunnels instead of capsule. I won't go through the procedure, but you can have same steps seen again and again. Inspect the tear. Once you inspected the tear, then you debride it, as we had seen on our earlier video. You debride it. If there's a lot of synovium, you remove the synovium. So you should have bleeding edges, or you should freshen the edges so that they heal better. That is the purpose of debriding. Once margins are clear, you can do a hook test to see whether fovea attachment is intact or not. Yeah, you pass in your probe and you try to rotate under the tear. Once hook test is there, then you can use a probe, or we can use it with the help of shaver also. Just try to lift the fovea. If it is lifting, that means fovea is also detached. So then you can put in guide wires, as we had seen, to the bone. Once you put in a guide wire, then you put a suture. Needle over it, then suture is passed, and then you can pass your loop over it to retrieve the wires. So this is how you can have second suture. So first one is mattress. Second one is simple suture to get the compression or opposition. So this is how we do it. So this was a complex tear. You can see complex tear, and gap was closed, passing multiple sutures. So it was combination of mattress as well as simple suture. This is how gap is closed. So using a jig, we can use a jig also by passing two KYs, parallel KYs through the jig, which goes on the both sides of the probe, which is intra-articular. Then you pass a fiber wire along it. Either use a fiber stick, or many times you are using a chia, or you can use any kind of a suture passer through the bone. It goes through the bone, through the cannulated K wire, or you've got the guide wire through the. This is how you pass through the needle and take out the fiber wire. Same thing again, and this is how you have a Mason Allen kind of a fixation. One is number 2 and other is 20, just so that knots are not very prominent. That is why using 20, but you can use number 2 sutures on both sides, or you can use 20 suture on both sides. There's no this thing. It's just from experience we find it better to use two different. So this is a Mason Allen type of configuration. So in algorithm, I would like to just conclude that if there is an acute injury, you do the splinting. If it is stable in a position, if it isn't stable in all position, you fix it with a wire, or you can do an internal bracing. If facilities available, arthroscopic TFCC repair in acute situation is also a good idea whenever you're doing a distal radius fracture. And after fixing the distal radius fracture, you find the DRUJ is unstable. In such cases, you can do it's 15 minutes extra, but patient saves a lot of pain and second surgery. If it is chronic dislocation without degenerative changes, a DRUJ reconstruction with a tendon anatomical Adam Berger procedure is advisable. If there are degenerative changes, the Saucompanji, other salvage procedures are also described using ECU SEO Amino tendons, which can be used. Replacement is still a thing which is not found its popularity. Even Shakers procedure have been done in which you change sigmoid as well as ulnar head. Long-term results are not very convincing because they tend to become loose because of the fixation on sigmoid, or the alignment is not very strict. So what we think, there has to be some kind of a floppy situation. It becomes too rigid, too tight, then movements are restricted. And in conclusion, I'll say arthroscopic, it is a very established, predictable procedure. Anatomical reconstruction like Adam Berger gives good results. DRUJ injuries are commonly missed, therefore you should commonly look for. The thing which I was trying to make, that people don't understand the utility of DRUJ. DRUJ is one thing, like it is thumb which is with us. DRUJ is also you can say humans are the unique in having DRUJ. So DRUJ is very important because what it does, it takes the load of the hand which goes through the distal radius in the wrist, then passes to the through the DRUJ to the ulna, then that load goes to the elbow. So it is not a vestigial organ or something of non-importance. It was our ignorance. We didn't realize it earlier, but DRUJ is a very important joint. So don't try to just excise the directs, though it is a very simple procedure, but it's a, you can say, always a compromise. So try to do anatomical procedure or other procedures as described. Thank you. So any questions I would like to take?
So may I ask one question?
Yeah.
So because we used to do just like a K wiring for the distal radioulnar joint, so I didn't get why we did it more proximal. I think I just didn't hear it. So you said that it is not at the level of the sigmoid notch. We did it more proximal to the notch.
Okay, we do it more proximal because if you're going through the joint, you're disturbing the cartilage, which we don't want to do. Second is, many times the bone bridge forms between sigmoid notch and ulna over 3 to 4
so we'll do like
So what will happen is synostosis, like there'll be stiff DRUJ. So it is always go proximally.
Okay, understood.
Okay.
So one question I would like to have. Sir, what do you reckon is the role of a distal oblique? But am I audible, sir?
Yeah, distal oblique ligament. Okay, I'll take it in the when we are talking about procedures. Actually, this was more of an algorithm. We missed on few procedures, especially distal oblique ligament, though it was described, I think, 20 years ago, and its importance is described. So we, as you have seen, we have reconstructed a few distal oblique ligament, but I will cover it under specific procedures when we are doing it, because this was more of an algorithm. So once algorithm is taken, then we'll take procedures one by one.
One more question, sir.
Okay.
Sorry.
Sir, what is the timeline which will put to distinguish between acute and a chronic DRUJ dislocation?
Usually people say 6 weeks, some people say 3 months. Anything more than 3 weeks, like, it's become chronic. But for us, like, we get cases late or they referred late. So 6 weeks, I'll say chronic, more than 6 weeks. Some people can extend up to 3 months. It is chronic and late. It all depends on MRI. How much is your tissues retracted, and whether you will be able to repair them or you have to reconstruct them. Like, you have to put a graft, or you can do repair end to end for any ligament, or you can say TFCC. If it is very old, very difficult, so chronic, so it's not a calendar, it's just an arbitrary guideline. Some people say 3 months, some people would say 6.
Okay.
Okay.
Understood, sir.
Okay, thank you. Okay, bye.
Thank you.
Yes.